Hey everybody, welcome to EMS Office Hours. I am Jim Hoffa and I'm joined by
Dave Brenner. Glad to be here, Jim. Thanks for inviting me.
no problem. And we're kind of waiting on Josh to join us as always, but as always, Josh is just a tad bit late. So if he jumps in, we'll add him to the video deal here. I want to encourage people, please, to hit the like button for us if you're watching this so we know you're here and that you are engaged with us, or hit the hate button or the squeezy heart icon or whatever it is that you like to mash on Facebook. And don't forget to go to emsofficehours.com and check out some of the content there. However, the hosting giants within the first responder network there is they're updating the entire platform. So the site is a little wonky and I have not been able to post many things on that site. So I'm kind of waiting for them to get that squared away. Because I hate to have to move the entire site into another platform and then have to spend a month trying to figure that out. So, all right. Dave, I wanted to I don't know, maybe this might not be that long of a podcast, but I kind of wanted to sort of address that thing of that a lot of providers do. I know I've done it where you have a patient, it's maybe a critical patient, maybe it's a pediatric, and you're trying to keep the family away or you don't want them engaged in what's going on. Um, Especially at cardiac arrest, it could be a lot for families to take in what they see us doing, to their loved one while they're sort of on the ground. We're doing CPR and poking them and prodding them and all that type of stuff. And I see a lot of people that will, um, not let the family near what's happening, and some agencies that I know of have kind of gotten away from that and sort of encourage you to let the family be a part of what's going on, you know,
Sure.
and because I know from my own personal perspective that when there's been times when the family member goes in the back of the ambulance and they're like, maybe we got pulses back or something like that, or they're very critical, and you say, oh, they're going to be okay, but then you get to the ER, and by the time the family gets to the patient's expired or they died, you know, um, and that's like a rough thing for family, for someone in the family to take in, that you're driving away from the scene, the patient in their mind is alive, and then you get to the hospital. They get to the hospital, follow to the hospital, find out that that they're dead. And with that said, Josh is here, so let me see, get him into the
Oh,
stream. Josh
Good
is
morning.
with us.
Josh, I've already written the inscription for your tombstone. Here lies the late Josh.
Do not even. I just sat down. I had everything ready. I was here 5 minutes early, and then a cup of coffee spilled over and decided to become a super liquid and absorb into everything instantly, including a sealed plastic bag where I had some stuff, and it got past the seal. So
That's
So
in
we
the
all-
book of
we're all getting
excuses,
our
page
interdimensional.
132. Blame the coffee.
interdimensional.
So, Josh, did you hear anything that we were saying a moment
Something
ago?
about doing CPR and keeping families away, and
Yeah, well, not just the CPR end of it. I mean, I bring that up as that's, I think, one of the biggest things that people can relate to. You know, the CPR end of it, where we don't let the family near the patient, we drive away, we don't let them in the ambulance, and then they never see their loved one again. When they get to the hospital, they go into the room and the patient's got to cheat over them. You know what I mean? But other things too, like the patients that are having an MI, and there's a lot of things going on, and there's a big chance the patient might not make it, or maybe they're in a third degree heart block or something like that, and you're feeling this patient is crashing, and I mean, the last thing we want is a family member in the back of the ambulance screaming and yelling and pointing out and asking questions, distracting us from what we're trying to do. But I don't know. I think that it's important that we let them be a part of what's happening. You know. So I just wonder what you guys take on that, even if you have
That's
personal experience with that, just to kind of share a little bit. What's that?
It's correct me if I'm wrong, Dave, but that's AHA guidelines now. We let the families, in. It used to be, I remember when I first started, that we would go into a bedroom, shoo everybody out, close the bedroom door,
Yeah.
work the code, and then if we needed to transport, we'd tell the family where we're going. And by the end, it was the door was open, a family member could stand. We would usually have somebody there, if we could have somebody explain to what was going on to the family, or at least ask them to say, listen, we're working very hard for your family member. We're trying everything we have in that we can, and we're not going to give up on this. So, keep on going. And then when we got the patient into the ambulance, a family member was allowed to ride up front, and then we'd go off to the hospital. And once we got to the hospital, the family member was escorted in, given a chair in the crash room, and and then the hospital took over counseling the family member.
So
I always saw that as a much more humane, much more connected way of allowing somebody to see that, it wasn't some black box. It didn't spit out either a person, a corpse, or a vegetable. It was, it was a real caring way of taking care of the other people who are injured by this call.
So I just want to do a historical perspective, because I probably go back before you guys, because my first experience providing ambulance care was in 1978. Is that ahead of you guys, right?
Yeah.
Yeah. And so the process was, as Josh alluded to, both at the scene and in the ambulance, family were discouraged from being in the room. They were, shooed out. Sometimes with somebody to speak to them, and sometimes just left out there alone. Sometimes a police officer would be with them.
Yeah.
And in the ambulance, when we got into the ambulance, we would tell them, no, you're not allowed, or they would say something like department policy. There was no department policy, but department policy was that you're not allowed. And so I would ask, even before the Heart Association came out with their guidelines on this, I would ask you, what would it take to keep you out of the room of the resuscitation of a loved one?
Which one are you asking? Because
Either one.
Your screen blacked out. I completely missed your first intro.
You mean, Dave, you're talking about if we were the family you're talking about?
Yeah, if you were the family of a person with a resuscitative effort going on.
Well, I'll tell you.
What would it take to keep you out of the room? In your house?
Well, listen, I'm a trained paramedic. I know what's going on.
That's where I'm coming from too, right?
But drop your paramedicine. Listen, you're a trained paramedic. If you're smart, you'll stay out of the resuscitative effort. You get into the hospital. If you're smart, you stay out of the resuscitative. I know we have a medical eye, but I'm just asking you, as a person who has a loved one, could be a child, could be a spouse, could be a mother or father or brother, whatever. What would it take for them to say, listen, we don't want you here, or you shouldn't be here? In my head, it would be, well, who should be here? I know you need to be here, but I need to be here too.
Really? When a loved one is being resuscitated, you're going to be that clear-minded that you're going to do that calculation in your head and saying, well, who should be here?
All right, so let me tell you.
I want to just say,
No, I'm asking you, who should
how many
be here?
times have you been on a job where somebody's thrown themselves on the body you're trying to resuscitate?
Once or twice.
Okay.
Once
I mean,
or
it's
twice.
happened. Yeah.
Once or twice. But that wasn't my question. First of all, let me be very clear. I'm an advocate for having family with the patient throughout the resuscitative effort, through any significant intervention that we do, every bit of it, including some of the horrifying things like drilling into a person's arm or leg, and intubation. I'm there for that because I have also observed prior to my enlightenment, all right, we take a person who's alive, we bring them to the hospital, and they're dead, and they're thinking, what the heck did you guys do?
Yeah.
What did you do? What is it you didn't want me to see? Would you guys have you stop at White Castle or something? I don't want to put down any place. Did you stop somewhere for a snack? You know, what's going on?
Well, that's the thing I'm trying to say too, David, is a lot of times when you get them in the back of the ambulance and they're alive, and not just, like I said, not just cardiac arrest, so that's, I guess, the most common, but other things too. And then you get to the hospital, the patient dies when they get there, and the families, I mean, this is the families say, well, what did you guys do or not do that somehow he died in that 10-15 minute ride, to the emergency room? And it's also this, I think it ends up being this negative perception of EMS that somehow we're incompetent because they die in our care.
Well, they can think that at a hospital as well.
Yeah, even if they died at the hospital, I'm saying. But in their mind, before they got, when you left, everything was, looked hopeful, and the patient was still alive, and so they start questioning what went on. I think, like you said, David, having them, involved in what's going on is important. And I think that, like Josh said years ago, that didn't happen. I mean, I would cardiac arrest, the bedroom door would be closed, nobody could come in, and then you send somebody out every 15 minutes to say, we're doing everything we can, there's been no change, and then start preparing them for the inevitable, where the patient wasn't going to come, wasn't going to survive, and you're going to go ahead and pronounce on scene, and you kind of escalate. Well, we're still trying to do it, but it doesn't look that hopeful. We're going to call the doctor, see what they have to say, and then the next conversation is, I'm sorry, there's nothing we can do. They're gone.
Right. I would like the family to see how hard we're working. I want them to. I would also like not to have the Three Stooges in the room providing care.
Well, sometimes I feel that's the problem, Dave. I think that sometimes, you're afraid that there might be other providers on the scene that either are a little flippant, or maybe, might say and do things that, from an outsider perspective, looks horrendous. You know what I mean?
Or you have a student on the scene.
Right, even that.
Students got to be there sometime.
Absolutely.
You got to model good behavior for them.
But you're a family member, or you're going in for surgery. You want a student cutting you open?
Yeah, everybody.
They're supervised. They got to do it sometime.
The first cut every surgeon makes is under the supervision of another surgeon when they were a student. Yeah, we've got a user who says they don't have faith in EMS. We have people who have no faith in any of the medicine. Doctors and nurses, and they feel that that they're not doing the right thing, and we can be part of that package. On the other hand, I would love them to see how hard we're working. I do it all the time when I'm doing it, and I tell them, to the degree that we're allowed, what's going on. This is what we're doing. This is what we're doing to save your loved one. This is what we're doing to help make sure they survive today. To have a good outcome. It's just the right thing to do. Mostly I'm thinking of parents, but I've done it also with spouses as well, and children with their adult children with their parents.
Yeah.
And what I don't ask them to do is sit in the front.
Really?
Yeah, really. I want them in the back with. I want them to see how hard I'm working.
How many crew members do you have in the back?
Sometimes 18.
Right. Right. And,
When-
you know, how many crew members are you allowed to have in the back when transporting?
There is no limit on in my ambulance. I don't know what you have on your ambulance, but if I can secure, listen, from my point of view, how many do you need? You don't need more than four. Four is like an enormous amount of people to have in the back. I got my friend Lucas on cardiac arrest doing compressions. You know, how many people can actually provide care? If you're lucky, you also have a ventilator, so you don't need that person either. You can run it all by yourself. But to the degree that I can, I invite the loved one into the back, as long as the patient is comfortable with it. They also have a say, but not children. They don't have a say.
We don't have Lucas. We don't have Lucas. So they're usually, you know, two people on the bench seat, one person in the captain's chair, and the patient on the bed. That's pretty tight quarters. Even when I've done this in the larger ambulances, we have our critical care ambulances, which provide a little bit more room. As you know, of course, it's insanely dangerous to have somebody stand up in a ambulance.
I'm not asking them to stand up.
And we don't have Lucas devices, as most functioning EMS across the country don't have Lucas devices.
Yes. I'm sorry to hear that.
I mean, you have, and I'm not in any way, shape, or form putting down what you just said. You have a system that has embraced both technology and you know, the skills and getting the equipment. Many ambulance companies don't have that, so they require, you know, you got the firemen, because you need two skilled people doing the resuscitation if you're still in the mode of dropping lines and giving medicine and, you know, giving.
Yeah, I think cardiac arrest, you have to have, I would say three providers is
right.
Good. You know, you have to have the two people that are managing the airway and compressions, and then somebody who is looking at the monitor, pushing drugs, monitoring the IV lines and stuff like that. So I think there's room to have one family member back there on the end of the bench. You know,
I have five legitimate seats in the back of my ambulance, not counting the patient. You know, so
five seats is about right. I would say is correct. So my thing is you know, you have to have room for equipment and for moving around and stuff too. So, you know,
and you don't just invite them in. Yeah, you want to check out the back of my ambulance. You got to tell them what's expected.
Right.
You got to tell them, you know, you're being invited in. You can't interfere. You can't interfere with our care.
I mean, I've had where you have the pediatric patients, and you want the parent back there with you, not sitting up front. You know, even if the child's in arrest or respiratory arrest or cardiac arrest, you want them back there. I mean, the one thing I want them to remember is the back of the doors closing and us driving away. You know, I want them to be with, and like Dave said, you know, want them to see what we do and how hard we're working to you know, resuscitate them. But I think you have to give them, and it, you know, time is limited because you're trying to get off the scene, you're trying to do other things that are involved around patient care, but you can take a minute to just explain to them, you know, if you want to come with us in the back, that's fine, but don't do this, don't do that. You know what I mean?
And there is a little bit of a difference in the back of an ambulance than the hospital, because in the back of the ambulance, if you're barreling down Highway 41, anybody know where that's from?
Bob Dylan. No? Oh, well.
Rambling there. Anyway, you're barreling down Highway 41 and the person, it becomes disruptive. It's not like asking them to step outside or having, you know, security come in and bringing them outside. You can't just leave them on the highway. But you also have to read. You have to read the people you're inviting in. You know, our environment is the least stable of the medical environments. So we need to read them. We need to tell them in advance. And I do want to point out, Josh, I'm very glad that you said about the Heart Association. You know, the Heart Association is just a reflection of the International Liaison Committee on Resuscitation. It's their stuff that makes ACLS and PALS and NALS and CPR, you know. So, And back in 2010, so if anybody's saying, who says the Heart Association said this? You go back to 2010 to the circulation, to the journal called Circulation, where they released the ILCOR results, and you look for the presence of a family during resuscitation in the PALS class. It's called Family Presence During Resuscitation, and they apply this not just to the back of the ambulance; they apply it to the medical scene, the medical. And they say, whenever possible, provide family members with the option of being present during resuscitation of an infant or a child. And let me tell you how strongly that's recommended, because there are recommendations and then there are recommendations. Like amiodarone. You can give amiodarone. It may kill them. It may not kill them. Give it. It's going to cause some damage. That's what they say about amiodarone, because that's a level 2B. But this recommendation is a class 1 recommendation. It's like epi during anaphylaxis. It's like defibrillating a person when they're fibrillating. It's like giving aspirin for a person with chest discomfort who's not allergic to aspirin. It is that good. It's like doing CPR on a pulseless person. So it's a level 1 recommendation. It's not a soft recommendation. They give you a way out. They said if the person's disruptive, respectfully ask them to leave or not join you. And that's what you need to do. And of course, that makes sense because the priority is the patient. I'm going to tell you, I wonder, is it that we haven't practiced it enough in class, what to do with the family? And I'm going to say that that's the issue. All right. Do you have to practice having the parents in the back of the ambulance when you're resuscitating their child so that you can speak to them? All right, because the worst call I ever had in my life was when my granddaughter was seizing for 40 minutes, and I was the tech. What a bad idea! What a bad idea that I was the tech. But I brought my daughter and my son-in-law in, and that was the right thing to do. But it was awful. It's awful to do that if you're not trained on what the right thing is to say, how to say it, how to behave. We need to train people to do it. We don't need to say, all right, so you know how to resuscitate, and now I'm giving you the baby's parents. I'm going to be in the back. What can you expect from them? Well,
So,
you can expect.
I don't need to, I don't want to, just tout my own service, because I'm pretty sure that there are other services that do this. And it's dependent upon the structure, the instructor, because it's definitely not a centered part of the curriculum. But when we do our scenarios during class, we set a chair aside sometimes.
You're talking about ACLS.
That's where the parents will be.
ACLS and PALS.
In ACLS.
I'm talking about in your
family
paramedic
member
class and your EMT class. That's where the comfort has to be. If you're not, you need it on your foundational training. You need the words to be taught to you, the situation to be explained to you, so that you can embrace it.
I agree.
And I mean, a person comes out of an EMT class, they can apply a traction splint upside down in the car in the rain at night because they've done it 37 times.
Right.
How many times have they spoken to the simulated parents of a child being resuscitated in your EMT class?
Well, this is, again, something that we've labeled as an issue within our training is, the non-skill based, and it is a skill, but the non-core skill based, focus in terms of, we focus on putting that traction splint on. We focus on the flying elephant scenarios more often than we focus on the day-to-day scenarios.
Yeah.
The day-to-day scenarios, we're giving verbal comfort to family members. Day-to-day scenarios, we're talking to our patient. Day-to-day scenarios are the things that we're doing paperwork and accurately logging what the patient said, what we said, our interactions.
And how much time did they spend in your original classes teaching you that?
And zero. That's not fair. We've,
almost zero.
15 minutes, half a class, whatever you want to say, it's not enough compared to putting on a traction splint in the rain, in the dark, upside down, with one hand tied behind your back.
There should be in your class. I don't know how many times you had to demonstrate a skill and get signed off That's a routine they talk about 3 times or 7 times, whatever it is. You know what's not listed there? Death notification to parents or to spouse. How many times
Absolutely.
it's
I'll tell you,
z-
Dave,
considered.
that was the one thing. I mean, is when you have to, when you're new and you find out, what do you mean I have to go out there and tell them that the loved ones, expired, or what, you know what I mean? And it's like, now you're like, how do I do this? And the only thing they say in school is, be honest. Don't use I'm sorry your husband's expired. I'm sorry your husband's gone. They want you to
dead.
say dead, say dead, say dead. Okay, well, but how do you do that? I mean, this is one thing. At TurboMedic, there's a presentation there about patient rapport, and it goes over how to read patients and how to kind of deal with family members on the scene and stuff like that, because it is something that is not, I think, focused on enough, in schools. The interaction, and like you said earlier, Dave, the one thing that not just like how to say it to people and practice that, and maybe have, when you're doing skills, have that person acting as a family member be there, for you to interact with, but also how to read people, how to read, who if you have a person who you feel is really like, kind of unhinged over the whole thing, you don't want them in the back of the ambulance, because they might be that person that flips out. And like you said, you can't really pull over on a highway or on a main road and start wrestling somebody when you're trying to do patient care. So you have to figure out how to read people. And that,
you don't want
I don't
them
know,
driving behind you.
without experience on how to read people, I don't know that's something that can be taught. You know what I mean? How to read people, whether or not they have a potential to be a problem, in the ambulance. I mean, half the time it's hard to read patients when you don't know when a patient might get violent with you. You think the patient's going to be fine, and you get in the back of the ambulance and they start flipping out and taking swings at you, and you had no idea that was coming. You know, so family members are something else, because you're not even really paying that much attention to them when you've got a critical patient. You're focusing on the patient, and now, okay, I didn't really focus much on the family. Is this person going to be an issue in the back of the ambulance? Are they going to be getting in the way? Are they going to do something like Josh said, where they throw themselves on top of the patient? You know, so I think it really is quite the balancing act that we have to do, with the patient care end of it, and having the family be engaged, showing them what we're doing, So I think it's very tricky, and I think the key is that it should be done in school, and I think there should be more CME opportunities for this type of thing. Stop with the constant the constant cardiology CMEs that people are falling asleep on, because they've heard the same stuff over and over again about ST elevation and all this other stuff. How about talking a little bit about this type of thing, so that people can actually take something away that they can actually use in the field that you see every day. Like Josh said, right? A lot of stuff, isn't gone over in school, of the things that we deal with every day.
Now take that,
and even talking to, not even, like Josh said, not even the patients that are critical, family members for patients that are critical, just every day interacting with patients. How you're speaking to patients every day. That is not done in school. It's almost
now,
I
and I
had to
just
learn how to
want
do
to,
it. No one taught me how to do it.
and I just
Granted,
want to
I am
sort
a
of
fast
defend.
learner and amazing, but that's how I was able to to learn. But a lot of people, they struggle with that in the beginning.
I'd just like to defend our profession a little bit with that said, Jim, and just say, when we roll into the ED with a code, what happens? What all of a sudden, all of those AHA positions that we were sort of described in class become a reality. They're because they have the resources to come in and handle, the family member. We have switching out CPR every 2 minutes. We have, somebody watching every aspect instead of giving drugs and counting drugs. There's somebody counting drugs. There's somebody giving drugs. There's an entirely different structure that I don't think is fully adapted to what we do. So on top of everything we do, including the lack of certain critical components of education, not the lack of education, certain critical components like how to interact with family members and such. We have on top of that, we have to sort of pick it up and go and be creative as we go along to take these things we're taught in an environment that's not similar to our own and bring it into our own environment. So now on the fly, we have to modify things we're taught.
And I do want to point out, as long as we're saying it, there is a curriculum now, as you may or may not know, called Psychological Trauma in EMS Patients, that the NAEMT office, the people who give us PHTLS and AMLS, it's called PTEP, Psychological Trauma in EMS Patients. And it's a fabulous course, not because I'm one of the authors, but I am, because it's a fabulous course. And the real content of it was written by mental health clinicians. I was bringing the EMS aspect in, I'm bringing the educational aspect in, but it literally puts into words, puts you into scenarios that you have to come up with, and it provides you with a structure, a codification. I remember when I first started in EMS, I was watching people get history, and some people were getting history like they were taking a shower with a water pick all over their body. And some people had a nice structured approach. Back then, by the way, it was ample. It was before sample, but ample. Right. And you figured out, what are you thinking? Well, I'm thinking ample. And as well, in this course, in this Psychological Trauma in EMS Patients course, there are 2 mnemonic devices to help you ensure that you provide the care, kind of like sample. It's escape and the M's and T's. And it works to tell you what to say, when to say, how to say it, and you practice it in this 8-hour class. Now, I will tell you as well, in LaGuardia, every EMT class and every paramedic class gets PTEP at the beginning of their course, and they have to use it throughout. And they actually get evaluated every time they're doing a skill. And it doesn't matter whether they're doing CPR or putting on a bandage on a laceration on the forearm. They have to use PTEP, and there is an evaluation for that. The National Registry of EMTs, on their skill sheets, speaks to the affective domain, right? Which is what this is. It's a structured approach to it. So they ask if the effective domain was used properly without telling you how to use it properly. And this class, PTEP, tells you how to use it properly. And by the way, I don't care where you are. It's not that I'm going to teach it. There are teachers all over the world now who teach this course. None better than the original authors, but they're all over. I'm teaching it in Kansas this August. So.
And just a note to our viewers, we have one of the original authors right here in our show.
Yeah. Well, listen, I think that, I don't know, I just wanted to kind of bring this up today because, like I told Dave off camera here, that I was talking to some people not involved in EMS about this and the reasoning why, it happens. And they were like, Dave said, if you were told to stay away, what would you do? And most of them were like, you couldn't keep me away from my kid or
right.
my husband or whatever. If something was going on, I'd have to be in the room. Now, I don't know, but maybe it turns into Josh said, that in the moment, maybe you're not thinking clearly. You're going to just kind of do what the professionals on scene are telling you to do. Like, go sit down over here. We'll be back in a few minutes to let you know what's going on, type thing. You know what I mean? But I think really, for me, the takeaway from the show today is, like Dave was saying, is that you want to encourage it. You want to have the training so that you can deal with it and you can read people and explain things to people and just so that when you do have them engage in the care, you do have them engage in what's going on, it's not dangerous to you or to them. It's not, doesn't become a hindrance in the patient care. And that goes back to being trained and how to do it, how to speak to people, and how to read people. So
I want to just throw something else at for viewers and people who are watching this. Don't be afraid of bringing, because you haven't been through like a program in how to read people. There is an aspect where your gut comes into play. Also, has that patient's parent been cooperative throughout your techniques, or have they been a little bit interfering throughout everything going on? At that point in time, you can make that judgment. If they've been there and they're you say, listen, just stand here, please. We're doing everything we can. It's going to be a lot of rapid movements, but I don't want you to be afraid. We're a good team, or something along that line. That's the person to, and they've been there, that's the person to say, hey, listen, here's a corner seat in the ambulance. A lot of stuff is going to continue. We're doing everything we can for your child. Just please sit there, and if we have questions, we'll definitely come to you, but let us work. And that's the person you can sort of strap in the back. With this said, it's been maybe 15 years that I haven't had a parent or an important family member along for the ride in the back of the ambulance. Now, sometimes, and even up to a few years ago, there was still the aspect where we put them in the front seat. Put them in the front seat, not necessarily because we don't want them in the back, but because I have a firefighter doing compressions, I have a BLS along, helping with some aspect, and I have me and my partner in the back as well. So we've already sort of taken up all the seats that are possible to take up, and plus with some equipment and other things, it gets crowded, and you don't want to trip around when you have sharps in your hand or anything else like that.
yeah.
So safety is going to always play a factor in your decision-making process, where you place your patients.
The only thing I will say, just to kind of wrap it up, Josh, is I understand with the safety thing, but one thing that I have seen too many people do is use the safety thing as a crutch, as a way to get people out. Oh, I don't need you. You can't come in the back. It's a safety thing. It's an insurance thing or whatever, which is all BS.
Horseshit,
so, I mean, there are times, I'm sure, where safety is an issue, but a lot of people just use it sort of as a crutch, as a sort of an excuse to quickly say, if this is a safety thing, it's an insurance thing, you can't ride in the back, but you can ride in the front. You know what I mean? Type thing.
Look, and with that said, you want to also add, safety is important for yourself. But once you bring a non-involved person in, I mean, there EMS agencies are cracking down on this, certainly, but not that hard, and especially not in the big cities, in terms of everybody gets a seatbelt when you're transporting, everybody's locked in, because we know that just doesn't happen. But if you bring a patient family member into the back, or even the patient themselves on the stretcher, damn well make sure that you've used all the restraining devices that you can to safely secure that patient or patient's family member. Because if you stop short and they get hurt, and then the evaluation comes by and say, well, were they wearing a seatbelt? Were they standing up? What were they doing? And you can't truthfully answer that, you're screwed.
Yeah. All right, guys, let's wrap it up there. Thanks for popping in. I really appreciate it. I like doing these a little bit earlier, in the day. And my brain is still waking up, and I'm getting the juices flowing. So I like doing that, but I know time is always an issue for everybody. So, thanks for joining, guys. Like I said, everybody, you can go to emsofficehours.com and look at previous episodes, or you can just go to iTunes and look us up there as well. I've not been able to do a lot of posting on the EMS Office Hours site because they are updating the platform there, and things are a little wonky on the site right now. So hopefully they'll get that going soon. And that's it. Guys, thanks for joining me. As always, I'm Jim Hoffman for EMS Office Hours.
I'm Josh Knapp.
And I'm Dave Brenner.
Stay safe, everybody.